My name is Dr Sara Meade. I'm a consultant clinical neuro-oncologist and I work at the University Hospital Birmingham, Queen Elizabeth. So I'm a neuro-oncologist. I treat brain tumours. So my main involvement with breast cancer management is treating brain secondaries. So I perform quite a lot of stereotactic radiotherapy with a machine called the CyberKnife. We also treat a lot of ladies post-surgery if they've had a brain metastasis taken out at operation, and we'll give them post-operative radiotherapy. So that's my main input with this group. With brain metastases, the symptoms are quite varied actually. We have some that it's picked up incidentally. They might have had a brain scan for another reason. They may have reported a mild headache to their oncologist and they'll do a scan and pick something up that's a bit unexpected. Unfortunately, the vast majority of them present with symptoms though, because we don't routinely screen the brain for brain secondaries at the moment. So they might present with stroke-like symptoms, they might have very severe headache, they may present with a seizure. So those are the main ways in which ladies tend to present. But we do sometimes pick them up early because they've had a scan for another reason, and then we can step in and help. So when a patient comes to their first appointment with someone like me as a neuro-oncologist, often they will have been told by their primary team that we think they've got secondary breast cancer in the brain. So they're anxious, obviously, to know that something can be done for them, but they're normally forewarned and know what the diagnosis is. I primarily treat them with radiotherapy, usually with targeted radiotherapy called SRS or stereotactic radiotherapy, using CyberKnife here in Birmingham. We are the only centre in the UK currently using CyberKnife. There are other systems that other hospitals use, such as Gamma Knife, and they use linear accelerators to treat these tumours, but this is our system here. Now, that first consultation, they often have a key worker from my team that they will meet. We'll have conversation about how they're feeling, try and get a bit of history about how this has all been identified. And then usually, because they're coming to see me, it means that I've looked at their scans and said, actually, I think there's something meaningful that I can do for you. We will be talking through what the treatment involves and trying to give them some reassurances that actually, most people tolerate the treatment quite well. We'll go through some of the side effects and give them some written information as well. But once we know about patients with this condition and we're offering this form of treatment happens quickly. So I think that's one of the anxieties for a lot of people coming to see me, is how quickly will I get my treatment? Will it interfere with my chemotherapy or the drugs that I'm taking for my breast cancer? And often there are very short pauses that we have to introduce, so we don't delay any of their systemic therapy, so we can hopefully alleviate some of those worries and anxieties that people come along with. I'm involved in some secondary breast cancer research around the work of brain metastases and early detection. Now, it's so important that we are investing and looking into supporting research in secondary breast cancer and not just primary curative disease, because actually many of the drugs that we end up using in the primary setting come because they've been trialled in the secondary breast cancer setting or secondary cancer setting for other tumour sites. It's really important for patients that they have access to new drugs and therapies to give them the opportunity to do well, live longer with better quality of life. As clinicians, we want to be able to have options that we can put on the table to patients, and it would be lovely to be saying, actually, you've got multiple options here, let's try this one first for you because of this reason. And if we don't have ongoing research into the condition in the metastatic setting, we run out of options earlier. But I do think the sort of the vision and the format really for research in secondary cancer is changing, and there does seem to be more focus, but there's never enough investment, and we need to keep pushing for that. Charities like Make Seconds Count are invaluable. They're funding really critical research that I'm involved in the near future, and without that funding we simply couldn't have run the study. Looking at screening the brain for secondary breast metastases. The concept of this came about in 2017, 2018, and it's taken us all this time through different channels and asking for money from different areas through national bodies, and being turned down from those because it's not going to necessarily generate lots of money, but actually it's such an important question that we're asking for the patients, and it's very easy to deliver, but we have to have the finance for that, and without Make Seconds Count we wouldn't have been able to deliver this to the level that we are going to be able to.